My name is Dr. James Beauvais. I'm a general surgeon here at Titus Regional Medical Center in Mount Pleasant, Texas. Today we're going to spend a little time talking about needle decompression of the chest to treat tension pneumothorax. This is a simple, straightforward, generally safe procedure. If somebody can start an IV, they can do this procedure. We'll start out by talking a little bit about what a pneumothorax means, how a tension pneumothorax in particular is a special case, and why this temporizing procedure can be life-saving. Pneumothorax literally translates into air in the chest. Of course, we always have air in the chest, but what we're really talking about is air outside the lung, but within the chest cavity, displacing the lung out of the way, creating an air bubble within the chest. This happens in cases of chest trauma, where a person is shot or stabbed during a car crash or a fall, where a broken rib can puncture the lung. Where we deal with it most often nowadays here at Titus is in the ICU, in patients that are on ventilators, and particularly during this age of COVID-19, patients that have lung disease coupled with ventilators that is causing what we call spontaneous pneumothorax, where even though there has been no trauma to the chest, the lung perforates and air begins to leak out of the lung and collect in the chest cavity. We've got a couple of chest x-rays for you to look at here so you can see what I'm talking about. The first image that's on the left side of the screen shows a right-sided so-called simple pneumothorax. If you can appreciate the left chest, where the heart is filled with lung markings all the way out to the edges of the chest, and then compare that to the patient's right lung, which of course is on your left side, you can see that there's a gap of air surrounding most of the lung, and the lung no longer fills the entire chest. That is the definition of a pneumothorax, also referred to in lay terms as a collapsed lung. What we don't see here, in this image anyway, is any signs of tension. Tension is a phenomenon whereby enough pressure starts to build up inside that thoracic cavity to actually compress and move the mediastinal structures toward the opposite side of the thorax. In the image that's on the right side of the screen, we see a patient with a completely collapsed left lung. You see no lung markings whatsoever on that left side. And more notably, the entire mediastinum, the heart, the trachea, the esophagus, is displaced drastically over to the patient's right chest. This would be a definitive chest x-ray demonstrating a tension pneumothorax. The reason this is so dangerous is that once enough pressure builds up inside the chest to compress the vena cava, blood return to the heart stops altogether, and the patient succumbs to death within minutes. And that's why tension pneumothorax is so dangerous. And the reason that we particularly worry about this in the ICU setting is when patients are on positive pressure ventilation and air is being forced into their chest cavity with a pump, a tension pneumothorax can develop very quickly. So as a matter of fact, we should be aware of the physical signs of tension pneumothorax and not necessarily have to wait for a chest x-ray like the one we've just looked at to make the diagnosis. Basically, if you've got a patient that has difficulty breathing with high peak pressures, high agitation, obviously lack of breath sounds on the side where the pneumothorax exists, distended jugular veins suggesting that the blood cannot drain into the vena cava, gapped rib spaces that are visible in thinner patients, any of those findings together with a patient that's obviously having problems ventilating and oxygenating should suggest to you that the patient has a tension pneumothorax. Now, definitive treatment for pneumothorax is a so-called chest tube, meaning we place a fairly large bore catheter into the chest that allows that air to escape and, importantly, keep escaping if there's an ongoing leak in the lung tissue. Needle decompression is not a substitute for a definitive chest tube with a large bore catheter. Needle decompression is a procedure directed toward immediately relieving the pressure in the chest and temporizing the situation until a formal chest tube can be placed. So let's look at the anatomy for a moment of this dummy, and we'll look at a couple of images on slides so you can see what I'm talking about with regards to where you would place a needle for this procedure. Anatomy to consider would be the suprasternal notch, that you can feel with your fingers right here at the top of the breastbone. Also, the infrasternal notch, which is the junction between the head of the breastbone and the body of the breastbone, also referred to as the manubrium. The clavicle on either side, and then the ribs themselves as they come down along the front of the chest. There are really two places on the chest cavity where we consider entering the chest cavity with chest tubes or to perform thoracentesis. For formal chest tubes, we're generally dealing with lower down on the chest cavity around the fifth interspace. That means below the fifth rib in the anterior or middle axillary line. When it comes to needle decompression, though, we're going to keep things a lot simpler. We're going to place a needle in the second intercostal space in the midclavicular line. So again, if you identify that clavicle and find the middle of it, and then reach below the clavicle to the first rib you feel, that is the second rib. So the second interspace is the space immediately below that rib, and it turns out to be right about here. In thin patients, this may be even visible. A lot of our patients are thicker, so you actually have to palpate with your fingers to know where you're going. Feel the clavicle, feel that first rib, know that rib that you're feeling is actually rib number 2, and then go over the top of that rib to the next interspace, and that's your second intercostal space, midclavicular line. And like I said, if you can start an IV, you can decompress a chest. The device we generally use is just a standard angiocath. Now, for this dummy, we're going to use a small one, which is a 22 gauge. As you might imagine, it might be a little short for some of our thicker patients, and not only that, but the gauge of the catheter is such that it may kink and block off very quickly, and therefore this is not an ideal catheter for this procedure. But for this dummy, it's the right thing to do. So once again, all I'm going to do is feel the clavicle, feel that first rib that crosses under it, travel down to the next interspace so I know I'm in the second interspace, and then at a 90-degree angle, we're going to insert that needle directly into the chest cavity. This can be done without a syringe attached to the catheter or with a syringe, so that you can apply back pressure to the plunger as you go in until until the syringe fills with air. Some people find that challenging because you're trying to both push the needle and pull the plunger at the same time. So most people would actually do this without a syringe attached to the catheter. The needle is removed, the catheter is left in place, and ideally, you would hear a hiss of air as the air escapes and the lung reinflates. Go back to our images for a second to see some graphic depiction of what I just talked about here. Of course, as with any other procedure, if we have the time, and we should prep the skin with an antimicrobial agent, at the very least an alcohol wipe. If we can get access to a betadine swab or a chlorhexidine swab quickly, that's a better way to go. Also, the device that we're going to use ideally would be considerably larger. I suggest a 14 gauge catheter, at least 2 inches in length, perhaps even 3 if they're available, because this catheter is large enough to stay patent for a longer period of time. It's less likely to kink, fill with a little bit of blood or fluid, and be useless very quickly. This photograph depicts the same situation with a real live patient. And they note there that the angle of the needle should be basically perpendicular to the curvature of the skin. The needle is removed, the catheter is left in place. The definitive chest tube hopefully is going to be placed within a short period of time. Keep in mind that if for one reason or another you're waiting for the individual that's going to place the definitive chest tube to arrive and signs of tension redevelop, you can pretty well guarantee that the catheter that you've just placed is already kinked or clotted off or no longer functioning, and you may have to repeat this procedure. Overall, this is a low risk, relatively safe procedure. There's not a lot of anatomy in this place that you could get into, particularly if you go straight into the chest and you don't try to go up under or over the top of a rib where you might hit one of the blood vessels that feeds the chest wall. And the biggest hazard, you might imagine, is that you actually puncture the lung with the needle. Well, the fact of the matter is, if you're using a relatively small needle in a patient that already has a pneumothorax, if you're making one more needle hole, that's less bothersome than tension pneumothorax, which is, of course, a life-threatening condition. This video shows that this is a simple procedure with relatively few steps. Hopefully, you'll never have to perform this on a patient in distress, but clearly you can see that it has the potential to be a life-saving maneuver.